Hello, my name is John Fanta. I'm a fourth year medical student at the Sanford School of Medicine. The title of my talk today is A Blue Patient Poses a Clinical Conundrum. If you recognize that title, it's because I was one of the poster presenters at last year's meeting, and they've invited me back to give an oral presentation of my work this year. Um, so first off, I just want to thank the South Dakota ACP for making this possible and organizing the meeting despite all the challenges this year. Specifically, I would like to thank Dr. Rob Allison and Chris Ram for organizing it and inviting me back to give my presentation. So with that, we'll get started here. As you may have guessed, my case involves a patient that presents with cyanosis. And so just for background information, cyanosis can either be central or peripheral based on the tissue that's affected. It'll be classified as peripheral cyanosis if it involves the hands and feet, while it'll be classified as central cyanosis if it involves the lips, tongue, and mucous membrane. And so peripheral cyanosis is typically less concerning as it involves vasoconstriction, which is usually from either cold exposure or through a Raynaud's phenomena of vascular constriction. While central cyanosis can be more worrisome, as it's usually seen in critically ill patients with impending cardiac or respiratory failure, and this is due to the reduced oxygen saturation in the blood. However, central cyanosis can also be due to an abnormal hemoglobin variant, so that's also something that should remain on the differential in a patient with central cyanosis. I've included images of peripheral and central cyanosis for your reference, just so you can see how these may present clinically. So in this slide, I have the causes of central cyanosis. And so I have them separated into two broad categories, one being those that are associated with reduced oxygen saturations, which include cardiac, respiratory dysfunction, as well as that associated with altitude. And in the other column, I have the two hemoglobinopathies that we'll dive into further throughout the presentation. And those are methemoglobinemia and sulfhemoglobinemia. So my patient presentation was a 58-year-old female that presented with a chief complaint of blue fingers and blue toes for the last 3 weeks. Recently, she did have some pain and frequency with urination, and she had been using azo urinary pain relief, or phenazopyridine, an over-the-counter urinary pain relief agent. She'd been using it daily for the last 2 weeks, almost 3 times per day. Her review systems was otherwise unremarkable, and her past medical history was also unremarkable. And notably, she had no history of cardiac disease or respiratory dysfunction. Moving on to physical exam, vital signs were normal outside of a pulse oximetry reading of 84%. She was, however, sitting comfortably and in no acute distress. Importantly, cardiopulmonary exam was normal. Skin exam revealed both peripheral and central cyanosis. Images of the patient's cyanosis are included, although the cyanosis is somewhat difficult to appreciate. Laboratory workup, including a CBC, UA, and CMP, were unremarkable. Co-oximetry testing was performed and revealed methemoglobin level of 33.2%. An ABG was also done and was normal, including a normal PO2 of 86%. Due to the patient's central cyanosis and high methemoglobin level, methylene blue was administered, as it's been known as a successful treatment for methemoglobinemia. Hours later, however, the methemoglobin level remained elevated at 32.7%. An additional dose of methylene blue was administered, and the methemoglobin level remained elevated at 31.7%. A blood specimen from this blood draw was sent to a reference laboratory, where methemoglobin was measured at only 0.2%. Out of concern that her urinary pain reliever was involved, phenazopyridine was stopped, and the patient was discharged with close follow-up. Through this all, she remained asymptomatic outside of her cyanotic appearance. At this point, it was believed that hemoglobinopathy was present. However, it was unclear whether it was methemoglobin, sulfhemoglobin, or a mix of the two. This diagram shows the formation of both methemoglobin and sulfhemoglobin. And so just a reminder from biochemistry, normal hemoglobin is made up of a ferrous ion, which is a 2+ iron, associated in a porphyrin ring. In the presence of oxidizing agents, however, the ferrous iron is made into ferric 3+ iron. This version of hemoglobin is unable to carry oxygen. The chart to the right includes drugs and chemicals that have been known to induce the formation of both variants in various case reports. Included in this list is phenazopyridine, the agent that my patient was ingesting in my case report. Interestingly, although sulfur is part of the structure of sulfhemoglobin, the source of sulfur is not well known. So I've talked a little bit about the formation of these two entities, and now I'd like to discuss how these entities present clinically. This chart shows a breakdown of the two disorders. Particularly notable is that far less sulfhemoglobin causes cyanosis compared to methemoglobin. Additionally, while methemoglobinemia is symptomatic at low levels and can progress to a life-threatening condition, sulfhemoglobin requires high levels to become symptomatic and is rarely life-threatening. The treatment is also different because methemoglobin is treated with methylene blue, while sulfhemoglobinemia is treated with supportive care and the cyanosis will resolve with red blood cell turnover. So to understand the distinctness of the clinical presentation of these disorders, it's important to go and understand the biochemistry of the hemoglobin dissociation curve. So just as a reminder, this curve shows the ability of hemoglobin to carry oxygen at various oxygen partial pressures. A left shift results in reduced delivery of oxygen to tissues, while a right shift results in increased delivery of oxygen to tissues. The presence of methemoglobin and sulfhemoglobin have two distinct effects. So, as I stated previously, the hemoglobin molecules that are oxidized by whichever oxidizing agent is inducing the formation of these variants are unable to carry oxygen. So that's one effect. The other effect, however, is important too. So the presence of methemoglobin causes a left shift in the remaining non-denatured hemoglobin molecules, while the presence of sulfhemoglobin causes a right shift in the remaining non-denatured hemoglobin molecules. So this effect at the molecular level actually explains why methemoglobinemia is such a severe disorder, while sulfhemoglobinemia is usually an asymptomatic condition. The patient followed up in 10 days. At her 10-day follow-up, she remained asymptomatic, but the cyanosis persisted. At this point, sulfhemoglobin testing was performed and showed a level elevated to 2.6%. This confirmed the diagnosis of sulfhemoglobinemia. An important thing to note about this case is that pulse oximetry and co-oximetry are not effective tools in distinguishing methemoglobin and sulfhemoglobin. They both rely on variations in the absorption spectrum to distinguish these two entities. In this case, the co-oximeter falsely reported sulfhemoglobin as methemoglobin due to the similar absorption at 626 nanometers. The actual value of sulfhemoglobin was much less than the reported level of methemoglobin, however. This is due to a difference in property of light called the molar absorptivity. It's important to note that testing for sulfhemoglobin is not routine for many labs, and in this case it required the blood samples be sent to the Mayo Clinic and results to be received several days after the patient had presented. So conclusions and take-home points for this case. A provider must maintain high suspicion for methemoglobinemia. Symptoms are nonspecific and it can be life-threatening if untreated, so prompt administration of methylene blue is appropriate. Secondly, phenazopyridine is known to induce the formation of both methemoglobin and sulfhemoglobin. Other drugs as well can induce the formation of both variants, so history alone won't help identify which variant is occurring in the patient. Additionally, pulse oximetry and co-oximetry is unreliable in distinguishing methemoglobin and sulfhemoglobin because of the similar infrared absorption peaks. Finally, this represents a common presentation of sulfhemoglobinemia. This presentation being an asymptomatic cyanotic patient with laboratory-reported methemoglobin that's unresponsive to methylene blue treatment. And of course, they are not in any acute respiratory distress because of the physiology of sulfhemoglobin. So these are some of my references that I've used throughout my presentation. And at this point, I can take any questions that anyone might have. Thank you for listening.